Recall from the pulmonary physiology talk that surfactant, which is produced by type 2 pneumocytes, is important for decreasing alveolar surface tension, increasing lung compliance, and decreasing the work of breathing. Now, the importance of surfactants is highlighted in neonatal respiratory distress syndrome, where pathology is related to the neonate's lack of surfactant. The deficiency in surfactant due to the immaturity of the neonate's lungs leads to an increase in surface tension, decreased compliance, increased work of breathing, and alveolar collapse. On chest x-ray, you can see these diffuse interstitial infiltrates. So who's at risk for neonatal respiratory distress syndrome? Classically, it's preterm infants, especially those before 35 weeks. Other risk factors include maternal diabetes and C-section. An important marker of lung maturity is the lecithin sphingomyelin ratio in the amniotic fluid. Both lecithin and sphingomyelin are lipids in surfactant, but it's mostly lecithin, otherwise known as dipalmitoyl phosphatidylcholine, that gives surfactant its properties. In neonatal respiratory distress syndrome, the LS ratio is generally less than 1.5. Whereas a ratio of 2 or greater indicates a low risk of neonatal respiratory distress syndrome. Survival is poor in neonates younger than 24 weeks. Treatment interventions include maternal steroids before birth to accelerate lung maturity, intra-alveolar administration of artificial surfactant after birth, and CPAP or intubation with oxygen. However, too much oxygen in the perinatal period can lead to complications such as retinopathy and bronchopulmonary dysplasia. Acute respiratory distress syndrome, or ARDS, has a number of causes related to illness or acute injury, like sepsis and acute pancreatitis as listed here. I would also add massive blood transfusion as part of the list. ARDS typically starts off as a patchy process that involves inflammatory cells like neutrophils and some T cells. Cytokines that contribute to lung damage that you might get tested on include TNF, leukotrienes, and macrophage inhibitory factor, MIF. In this histopath image on the right, you see inflammation, edema with proteinaceous fluid and hyaline membranes, which has this glassy pink appearance when you stain it with H&E. So here's a bit of board trivia. In which condition were hyaline membranes first observed? The answer is neonatal respiratory distress syndrome, which we just discussed. In fact, neonatal respiratory distress syndrome is also known as hyaline membrane disease, and in fact, this particular image could pass for NRDS. On chest x-ray, you can see patchy, diffuse, bilateral infiltrates as seen in this intubated 21-year-old with a history of aspiration pneumonia. Management of ARDS has gotten better, but it's still a deadly condition. Mortality rates used to be as high as 70%, but have now dropped into the 30s. Patients typically require mechanical ventilation over a long period of time with low tidal volume. However, during the course of treatment, oxygen radicals from high FiO2 levels can cause what's called diffuse alveolar damage, or DAD. Now let's compare obstructive and restrictive lung diseases. This is kind of a quick recap from the past couple of pages. As you recall, the FEV1 is the forced expiratory volume over 1 second and is influenced by lung compliance and elasticity. Forced vital capacity is the absolute volume of air that can be exhaled. In normal lungs, the ratio of FEV1 to FVC is approximately 80%. Obstructive lung conditions, as you can see here, have lung volumes that are higher than normal because of air trapping. Specifically, total lung capacity, functional residual capacity, and reserve volume and residual volume are all increased, and the FEV1-FVC ratio is less than 80%. Can you point out the volumes in the middle diagram? Well, here's the total lung capacity, right? And then you have the residual volume over here, which is what you have left after you exhale your vital capacity. So where's the functional reserve capacity? That's a trick question. Since this diagram shows a forced exhalation, you won't be able to see the lung volume after normal exhalation, which would be the functional reserve capacity. So how would you contrast this with restrictive lung disease? Obviously, you can see a big decrease in lung volumes. That being said, there is a comparable reduction in both FEV1 and FVC that results in an FEV1 FVC ratio that remains greater than 80%. Note, however, that the total lung capacity in restrictive lung disease is dramatically reduced and the volume curve is shifted down relative to normal lungs. Sleep apnea is becoming more and more common as the prevalence of obesity increases. An apneic event is defined as the sensation of breathing for at least 10 seconds. This leads to disrupted sleep and the classic presentation of daytime somnolence. When the apneic event occurs in obstructive sleep apnea, or OSA, which is the most common type, the respiratory efforts continue against airway obstruction. Because you have alveolar hypoventilation and hypoxia, you can get a secondary polycythemia from erythropoietin release. You also get pulmonary arterial vasoconstriction in an attempt to shunt blood, resulting in pulmonary hypertension. So does this remind you of anything? It should make you think of COPD, where you see some of the same complications. You can also see right heart strain and the development of associated arrhythmias, so sudden death is a possible clinical presentation for patients with sleep apnea. When you see obese patients with daytime somnolence, you typically think of obstructive sleep apnea, but these patients can also have obesity hypoventilation syndrome separate from or in addition to obstructive sleep apnea. This is also known as Pickwickian syndrome. How can you tell the difference? The ABG in a patient with obstructive sleep apnea is usually normal. However, if you have obesity hypoventilation syndrome, you'll typically have daytime hypercapnia with a PaCO2 greater than 45 millimeters mercury. Central sleep apnea is less common and involves the absence of a respiratory effort due to a failure of stimuli from brainstem command centers. In other words, this is a neural issue, not a mechanical obstructive issue. So, what causes sleep apnea? Well, things to keep in mind include narcotics, heart failure, and renal failure, as well as a recent ascent to high altitudes. Obstructive sleep apnea is typically treated with weight loss, continuous positive airway pressure or CPAP, or airway revision surgery. With central sleep apnea, you have to treat the underlying pathology in addition to supportive care with CPAP. The Step 1 respiratory case vignettes will often discuss lung physical exam findings. Here we'll try to identify the high yield patterns that will help you clue into the diagnosis faster. If you hear decreased breath sounds at one or both lung bases, especially with dullness to percussion and decreased fremitus, you might think pleural effusion. Now remember that fremitus is a palpable vibration you feel with low frequency vocalization. We'll talk more about pleural effusion later on in this section on page 561. If you have a similar presentation but with tracheal deviation towards the affected side, you might think atelectasis and bronchial obstruction since you get the tracheal deviation as the lung collapse distal to the obstruction. We'll talk more about pneumothorax on page 561, but this is a situation where you have a collapsed lung. This is really the only condition where you expect to see hyperresonance. In spontaneous pneumothorax, the trachea tends to deviate towards the side of the lesion. With a tension pneumothorax, the tracheal deviation would be away from the side of the lesion because the trapped air on the side of the collapsed lung pushes the mediastinal structures like the trachea to the other side, as in this chest x-ray. Finally, if you have increased tactile fremitus, you should be suspicious of a pneumonia or any other consolidating process. Lung cancer remains the leading cause of cancer death among both men and women. Suffice it to say, this topic is very high yield for step 1 and you're going to want to put a big star by it. Lung cancer may clinically present with cough, hemoptysis, and so forth, or it may show up as an incidental finding on chest x-ray or lung CT. Metastasis to the lung is the most common malignancy you'll find in the lung. Mets are typically coming from primary tumors in the breast, colon, prostate, and bladder. On the other hand, when primary lung cancer metastasizes, it most frequently goes to the adrenals, the brain, the bone, and the liver. The complications and sequelae of lung cancer are pretty high yield, and the Sphere mnemonic does a pretty good job of summarizing them. Other than these conditions causing their own set of problems, why is it important to know these complications? It's important because they are often the first signs and symptoms of lung cancer. So if someone has ptosis, meiosis, and anhidrosis, as in Horner's syndrome, and a cough, you may want to think about a lung mass. We'll talk more about these complications on the next page, but for now, let's talk about the different lung cancer types. As we go through the various lung cancers, keep in mind their typical location in the lung, whether or not they are associated with smoking, their associated symptoms, and the histologic characteristics. Adenocarcinoma makes up about half of all primary lung cancers, so it's the most common one out there. The bronchial subtype is more common in non-smokers and in females. It usually occurs in the peripheral lung parenchyma, often at sites of prior injury or scarring. The bronchoalveolar subtype is much less common and is not related to smoking and typically spreads along the alveolar walls. On histology, you'll notice the involvement of Clara cells, or type 2 pneumocytes. Fortunately, if you catch this lung cancer early, it can be surgically resected. Squamous cell carcinoma has been clearly linked to smoking and typically presents as a centrally located hilar mass arising from the bronchus. Now, hypercalcemia of malignancy may be seen with squamous cell carcinoma due to the production of parathyroid hormone-related peptide. You may recall from the endocrine chapter how parathyroid hormone stimulates osteoclast activity, thus releasing calcium from the bone. Histologically, you are looking for keratin pearls in intracellular bridges. Can you point them out on these images? Well, here's a keratin pearl, or a couple really, and here you see prominent intracellular bridges, almost like tram tracks throughout this image. Of the common primary lung cancers, this would be one of the better ones to have because it's resectable if you catch it early on, and it has a relatively good 5-year prognosis. On the other hand, a small cell or oat cell carcinoma is extremely aggressive and poorly differentiated with a terrible prognosis. Small cell carcinoma is a centrally occurring lung cancer. It can produce excess ACTH and ADH and can cause different paraneoplastic syndromes. Think for a moment how these might clinically show up. With excess ACTH, you may have excessive cortisol release and a Cushing-type syndrome, while excessive ADH, in the absence of normal stimuli, also known as the syndrome of inappropriate ADH, or SIADH, leads to what type of findings? It leads to fluid retention and hyponatremia. You can also get autoantibodies against neuromuscular junction calcium channels, causing Lambert-Eaton syndrome. What's the hallmark presentation of Lambert-Eaton syndrome? The classic presentation is a patient with proximal muscle weakness. On histology, you'll notice the chaotic or undifferentiated quality of this lung cancer. And on the left, we have another example. The small dark blue stained cells are the neuroendocrine Kolchitsky cells. These can lead to some of the paraneoplastic syndromes we just discussed. This type of cancer tends not to be resectable. Why is that? It's because metastasis occurs very early on. It can be treated with chemotherapy, but as I mentioned, it has the worst 5-year prognosis among the major lung cancer types. Large cell carcinoma tends to be peripherally located. This type of lung cancer also has a very poor prognosis when compared with the other non-small cell lung cancers. It's not really responsive to chemotherapy, and surgical resection only works about half the time. On histology, you can see the large undifferentiated cells with mucin vacuoles, thus of course the name large cell. Carcinoid tumor is an interesting but uncommon lung cancer that carries a fairly good prognosis, which makes it perfect for testing on the USMLE Step 1. This typically presents as a bronchial obstruction with coughing or hemoptysis. If you were to biopsy the mass, histologically you might see carcinoid cells in these classic rosette patterns here, here, and a little here. Occasionally you can also see it present as carcinoid syndrome, where you get flushing, diarrhea, wheezing, and salivation due to the tumor's production of serotonin. You can also get fibrosis of the tricuspid and pulmonary valves from high levels of serotonin, which can lead to right heart failure. So here's a possible board question. If you have someone who presents with carcinoid syndrome, where else would you look other than the lung? Well, carcinoid tumor most commonly occurs in the small bowel and the appendix. However, you usually don't see the carcinoid syndrome unless it metastasizes to the liver, because the substances released by the carcinoid syndrome in those locations are typically metabolized and inactivated by the liver. Well, getting back to the lung, the good news is that this type of tumor tends to be slow growing and does not metastasize frequently at all. This is mainly treated by surgical resection, and the 5-year survival rate is really good, 75 to 95% compared with the other lung cancers. Finally, mesothelioma is a disease of the pleura, although it has also been diagnosed as a disease of the peritoneum. As we discussed earlier, this highly malignant disease is a result of exposure to asbestos. Of course, the risk is multiplied with tobacco smoke. It's characterized by pleural effusions, plaques, and thickenings, and it has a high mortality rate. This is a chest x-ray of a 67-year-old gentleman exposed to asbestos 40 years ago. Can you tell me what you see? You can see large pleural-based masses in the right lower lung with loss of right lung volume, likely due to scarring and atelectasis. And on the right here, you have a coronal reformat of a chest CT in a patient with left side mesothelioma. You can see the extensive pleural mass with contraction of the left hemithorax. On histology, you'll see psammoma bodies, which are laminated calcifications. These happen to be examples of psammoma bodies from a meningioma. You can go back to page 223 of the Pathology section for more discussion on psammoma bodies.